Good morning, everyone, and thank you very much for joining us on this rather cold day in tent 4. I'm glad to say I'm not in a physical tent, otherwise this might be a little bit of a cold, wet affair. But for the next hour, we're going to talk about the growing trend of evidence-based design in the health and care environments. And with so much going on around hospital build and design at the moment, I think it's really important to get some of to get the information flowing and sharing from people who have gone down the road already in when it comes to the design and build of new health and care environments. Because it's a long way from just sort of like putting beds in a room and calling it a ward and then moving on. So I'm very pleased to welcome our panelists who will introduce themselves very shortly. So we have Rob Selley from the new from Bart's NHS Trust, who is working on the new Whipps Cross Hospital. We have Amanda Sparks from Royal Free, who will be sharing her experiences when it comes to the new Chase Farm Hospital that is opened there. And we will be moving to Newcastle up north to speak with Chris and Allison on the work that they have done on the redesign of the inpatient and outpatient units. My name is Deirdre Stewart, and I'm a nursing executive and senior director with Cerner in the UK. And part of my interest in this has been helping out with and reviewing new build hospitals around the world. So it was a real pleasure to be invited to do this session today and to welcome you. It will be recorded, so obviously people who cannot attend live will be able to access this over the coming months. But I'd like to kick off. The session will be 1 hour in total. I will kick off with some questions and then we invite audience participation. So whether you want to put your questions in the chat or you want to come off mute when we've done the sort of like the introductory round of questions, you will be able to do that and you can ask our panelists live. So I would like to start off by asking each panelist in turn to introduce themselves and to talk a little bit about what has led you to your role. So, I mean, Rob, can I hand over to you and ask you to tell us about your career? One of the reasons I'm asking this question is because an awful lot of people want to know how can they get involved in the future of new build and design, and they don't know where to start. So from your career as strategy lead in Whipps Cross for the Whipps Cross Redevelopment Programme, what has brought you to this stage?
Thanks, Deirdre. Hi, everyone. As Deirdre rightly said, I'm Rob Selley. I am the healthcare strategy lead for the redevelopment. So I'm working as part of a team who are tasked with putting together a business case for the new Whipps Cross Hospital, which is one of the frontrunners in the new hospitals programme. My background is clinical. I've been a nurse since the year 2000. I've worked in various roles, mainly in critical care and in polytrauma. My roles, both those roles were at the Royal London Hospital, where when I was a ward manager, I transferred from the old Victorian Royal London Hospital to the new PFI building, which is where I really got my first experience of design and working with designers to build new hospitals. Since then, I've moved into more ops-based roles as Deputy Director of Ops at Whipps Cross Hospital, where I worked very closely with our estates team, working on our fire remedial works programme. So I think after Grenfell disaster, I think we had the London Fire Brigade came around to look at all the hospitals in London and kind of gave us some tasks by which to make the hospitals feel a lot more safer, which for Whipps Cross, which is mainly largely a Victorian building, and quite a bit of work closing down wards, redesigning them, putting more fire safety measures into all of those wards. So it did mean quite a lot of clinical design. So with the estates team, I was part of that. In 2019, we started to develop the strategic outline case for the new hospital, and I joined the team not long after that. So that's kind of how I got into working in my current role as strategy lead.
Very good. I love hearing these stories about how people get from, when you first go into nursing, you think, okay, I'm going to be a nurse. But then, I mean, the sort of like the options are infinite after that. And I think your journey describes that really, really well. So thank you for that, Rob. Amanda, as the Divisional Director of Operations and Nursing for the Royal Free NHS Trust. And I had to write this down yesterday because it was quite long. The Centralised Elective Access Centre Director as well. Please tell us a little bit about your journey to where you are today and how you got involved in the design of the new Chase Farm Hospital.
Thanks, Dee. Yeah, I'm not going to repeat that. That is the job. I'll try and explain it a bit further as I talk. But essentially, clinical by background. So I've been a nurse for 23 years, and still would describe myself, if someone asked me what do I do for a living. Nurse is the first thing. It's so much easier to say that, and once a nurse, always a nurse. But yeah, most of my background was in surgery, so landed in a rotational post, so ED, ICU, landed myself in surgery and kind of grew up in district general hospitals, and all the way through, a bit like Rob yourself, ward manager, favourite job ever, and then I jumped into some corporate roles, so took the lead for those that remember Productive Ward or the Productive Operating Theatres programme in 2012. So I ran that in the trust I was working. So that was my first real taste of change and improvement and transformation, and then went back into a clinical role from that, matroning, then moved to the Royal Free, took a head of nursing role, and of course the Royal Free at that time were embarking on their full business case to design this new elective hospital at Chase Farm in Enfield, and it was a really exciting programme, and I joined that programme as the senior clinical ops, so that was my first kind of dual role, managing business as well as the clinical services and the professional nurse line management for nursing, and then into the role I'm in now. So I've kept that joint role of managing ops and nursing, and now have the added bolt-on of the Elective Access Centre, which essentially is a centralised bookings team for the Royal Free London. So I have that nice kind of envelope of elective activity to run here, and was part of the design, the programme, the commissioning of the new Chase Farm Hospital. So yeah, that's probably 23 years in 1 minute.
It sounds like a lot more than 23 years to have squeezed that amount in, but thank you very much. And I know we'll be going into quite a bit of detail around some of the things that we discussed on Chase Farm yesterday. So let me come slightly north, not as far north as I am, because I'm up in Scotland on a grey, rainy day. But Allison Deagle. Allison is matron of the digital transformation in the Newcastle Newcastle upon Tyne NHS Trust. Can you tell us a little bit about yourself and your involvement in how you came to be involved in the sort of like the planning and digital transformation activities that are going on in Newcastle?
Yeah, so I've been nursing slightly longer than the other two participants so far. I've been a nurse for 29, nearly 30 years. Came straight in, new nursing was what I wanted to do. So did a bit of everything, moved around quite a lot as a staff nurse, worked on surgery, medicine, A&E was my main area, A&E and infectious diseases. I then moved into working for the ambulance service for a while, and then moved into primary care, working for the PCT. Worked in general practice for a long time, and then came back into secondary care in about 2008, 2009, back into ED. Then I moved to the walk-in centres, became team lead for the walk-in centres for Newcastle, and during that time we went through a big transformation. So I became involved in developing a new service, a new outreach service, which was really my first step away from direct clinical care. I was always very much, don't want to move away from patient care, want to be very patient focused, and always thought moving away from patient face and took away that clinical element to it. But doing this project really showed us that that's not true. So moved into my matron's post following that project work, and I was matron originally for urgent and primary care, which encompassed the outreach service, the urgent treatment centres, and chronic disease monitoring, TB service for Newcastle, and then took on, about 3 years ago, took on sexual health as well, which was a huge learning curve for me for that, because it's a completely different way of working to every other service that I'd worked with. And in February this year, I moved over to be matron for digital health team. So we have been using electronic patient records for about 12 years, and gradually have moved over completely to all electronic patient records. So that was November 2019, we went live with electronic patient records. And then of course COVID hit, so it was put on the back burner a little bit, although we still use the electronic patient record. There was no optimization work done. So in February this year, the digital health team came into fruition. So we are a small team of clinicians who are looking at the optimization of the system, making it easier for the staff to navigate, which will in turn free up time to care for the patients. And that's what it's all about for me. I discovered that actually you can touch much more, affect many more patients' journeys doing this type of role than actually being forward facing with the patient. So within the team, we are very much seen as clinical. We want to be known as clinical staff. We don't want to be IT, which I think sometimes can happen. So being out and about, visiting the wards, seeing what's happening on the departments is very important, and that's really how we became involved with the digital strategy as well, and with the new builds that's going on at the moment, looking at patient flow.
Very good, Allison. And Chris, you're going to have to give us the amount of years that you have done as well in your introduction. And I have a reason for asking this. But Chris, as the assessment suite matron in Newcastle upon Tyne Hospitals and NHS Trust, tell us a little bit about yourself and your career and how it has brought you to this point.
So I would probably say I'm probably the baby of the group, let's just say. So I've been working as a nurse for 15 years. Always wanted to be a nurse. Originally did my training and qualified in a small hospital in Darlington. And then after about 4 or 5 years, moved up to the Newcastle hospitals, where I've been ever since. My background is a medical nurse by using, normally working on medical assessment wards. I then went and became a ward manager on a gastroenterology ward, and then missed the pace and the unpredictability of medical assessment wards and went back there. And from that, I then became a matron. My role's slightly changed probably in the last 3 months. So I am on secondment 2 days a week as well as an Associate Director of Nursing for informatics, working alongside Allison, as well as being a matron in medicine, looking after a number of wards. I still do regular bank shifts, doing regular shifts on a weekend. I think that's really important for me to remember why I became a nurse, and also understand some of the constraints and issues that the nurses face. I think sometimes it's really hard sitting in a room listening to how people talk about things, but actually doing it and being part of that, I think, gets the message out there that yes, we are still clinical, we do understand, and you can actually take that to a lot of meetings. Currently, I'm in the process of working. Some of the wards will be moving into a new wing that the trust are redesigning. So it's about understanding from root cause analysis, complaints, patient experience, how actually we can improve that environment and workspace to try and reduce some of those risks. So yeah, that's kind of me in a nutshell.
Excellent. So one of the reasons I was happy that you all shared the amount of time is I'm not a mathematician and I don't have a calculator on me, but by my calculation, just between the 4 panelists, you bring 87 years of clinical practice and experience to this panel. If I was to add my own, I'd be 40 years, but I won't. But 87 years of acquired knowledge, and you can see from ambulances to inpatients to surgical to, to design. It's a huge amount of knowledge that you are bringing to this session and sharing with everybody who is logged in. So thank you very much for those introductions. And it's so true what you say about keeping in touch with what is going on the floor, so you understand what is happening is of vital importance. Learning from the past to go ahead. We'll touch on a little bit of that later on. So for the next part of this session, what I want to do is take it from sort of like, how do we move from big picture, which is the strategy? How do we need to create the hospital of the future? I'm looking at that with Rob and the work that they're doing for Whips Cross, for the new Whips Cross. And then we will take it sort of like down another level to Chase Farm, which has actually been built and is open and live and is running as the product of what the initial, how the strategy was rolled out. And then we will go a little bit into more detail about the redesign of specific sort of like inpatient and outpatient units with our team in Newcastle. As I say to the audience, pop any questions you want in the message. On the message board, we have that being monitored, and there will be a chance for you to come in and ask questions afterwards of our audience panel. So Rob, over the next little while, is it okay if I start with you and ask you a little bit about, what are the major components of the Whips Cross digital strategy, and how does that align with the blueprint for digitally advanced hospitals in the work that you've been doing?
Thanks, Deirdre. Yeah, so obviously it was really important when we started to design the new hospital that we thought about digital and created a digital strategy for the rebuild. One of the things that's always really had to play a significant part of our thoughts really is around the fact that we're a trust. So we're not just Whips Cross Hospital, but we are a group of 4 hospitals. So we have Royal London, St Bartholomew's and Newham as well. And it's been really important to consider how we do transformation, not only at Whips Cross, a brand new building, but how we can ensure that transformation rolls out into the other hospitals as well, because the trust was created to make accessibility to NHS care equal across the whole of East London. As we move into the North East London DCG and how we work as a sector, I think that's even more important. So it's been really that's been a major factor really, and a big component of part of our digital strategy. Is yes, Whips Cross can certainly be the testing ground for the new technology, but it needs to be something we can get assurance that we will be able to roll out into all of the other hospitals in our trust as well. And thinking about that obviously is where we are at the moment. So we've got quite an established informatics strategy, which we've been working through as an organisation for the last sort of 5 years, and that's been really important to consider how we've been working so far and where we've wanted to get to, and then how we take that forward in the new hospital as well. So the current trust informatics strategy has been really important too. And then of course what I'm responsible for is the health and care services strategy, which is around how we've developed models of care in the new hospital and how those models of care will run through the building. We know that there's significant transformation that's going to be required to get to the stage before we move into the new hospital to enable us to go live with those models of care. So it's really been how digital can support the changes in the models of care that we aspire to have. I could take an example for that would be the outpatients. So we were really keen because partly we did have to build a smaller hospital than we've currently got. We were really keen when we first did the strategic outline case was to try and reduce outpatient footfall by about 50%, which means we'd have to go to digital outpatients and virtual outpatients, which at the time everyone thought we were crazy, and then we didn't anticipate COVID coming along, and then during the peak of COVID, we were actually delivering nearly 99% of virtual outpatients. So it just goes to show what can be done when it needs to be done. So in some ways, and don't take me wrong on this, COVID was a good thing for us because it just identified actually what we could do when needed to be. So obviously, being a digitally enhanced hospital is going to be really important to deliver easy virtual outpatient capacity for our patients and our staff to access.
And what about, so you say sort of it was important to get patients onto the right pathway immediately. Does your strategy also involve how to move your patients sort of like quickly through the system? So you'll identify them early, presumably at the front door, get them onto the right pathway. But is it going to enable you to maybe discharge patients earlier, have care nearer to home, or?
Absolutely, yeah. So we've basically got 3 principles for the redevelopment. The first one is that patients will only really come to hospital if they absolutely have to. Most of the care we would like them to be delivered closer to home. So whether that's in community centres, through the GPs, and through community services, that's really where we want the most of the healthcare to be delivered. If patients do need to access hospital, then we do really want to get them onto the right pathway. We don't want everyone turning up to A&E. We want to ensure that there's different pathways into the hospital, but ideally via planned care rather than unplanned care. So our desire is to reduce the amount of unplanned care that we have in the hospital and to transfer as much of the care to planned as possible. And thirdly, when you do have to be admitted to hospital, that we have got a streamlined approach to care. So there's no waits for diagnostics, there's no waits for beds. There's a streamlined discharge out to care providers in the community or back to home. So it's been really important to consider that. So we have had to work not only just as a hospital trust, but also as a whole care system, which means, in our strategy team, we're working really closely with our community providers, with the local GP Federation, with the CCG, to consider how well all of our systems line up and how they talk to each other. We're quite fortunate in East London that we've got the East London Healthcare Record, which is one of the location-based records that started a few years ago, and that's gone from strength to strength. And now all providers have access to the care record, which means that they're able to. A doctor at one of our hospitals can look on the care record and see some of the community notes, and a GP can look and get summaries from care that's happened not only in the hospital itself, but also from the community services as well. So that's been really, really key to be able to do that, and that's one of the biggest conversations that we've been really having since we've been going, is to think about how we align all of those services. And that's quite a big part of the transformation role, which is the other half of my role, along with designing the hospital, is about ensuring that the transformation that we need to get to happens before we open the hospital.
Very good. And finally, do you know how much less space you have for the new Whipps Cross Hospital versus the old one?
So anyone who's ever been to Whipps Cross will know that it actually sits on the biggest site in London for a healthcare site in London. We have around 90,000 square metres of space that we currently use. There's a lot more that's derelict, and that's currently what's being knocked down to provide space to build the new hospital. The new hospital, the current hospital, has around 50% clinical space and 50% non-clinical space, which has happened for numerous reasons over numerous years, that we've added space, and it's been for the community and local healthcare providers. It's been a place where we can put services because we've had space to put services. But obviously, going forward, we want to take some of those services back out into the community. So we've needed to look at that. And what we do have a desire to do is to make the hospital 75% clinical and 25% non-clinical, which has led to some really difficult conversations, because some of that non-clinical space is consultant offices, or big areas that the staff have kind of adapted and used over the years, and we've had some really difficult conversations around about how we can streamline that space. I think everyone signs up to the fact we need more clinical space, we need better clinical space. So that's a really easy argument. And I think everyone signs up to that. But it is around how we work differently. I mean, from COVID, we've had an agile working policy that's been put in place across the organisation, meaning some staff are working from home for some days and others working on the site. And that's something that we're going to have to, improve on and look at more closely as we build the new hospital, because we can fit everyone in and everyone will be able to work, but it's going to mean agile working, it's going to mean working across the sites, and it's going to mean a real blend of doing that to support only using the 25% space. Obviously, COVID has also taught us that we really need to have good staff support services on site, so places where staff can relax and rest in really difficult shifts. So we've had a real focus on, working with our staff to think about what they need from that sort of space and how that can be best delivered, but also how it can be delivered in a sensible way that can contribute to the reduction in the floor space for non-clinical space that we need.
That is excellent. Thank you very much, Rob. And I saw Amanda smiling there. So especially when you were talking about the reduction in space, we had a very interesting prep call yesterday, sort of like discussing some of this. So I'm going to swing right across to you, Amanda. And I have to start by saying the new Chase Farm Hospital, I was actually down there helping out with the go live of the EPR, and I walked in and I just thought, oh gosh, this is just a beautiful, beautiful place. It was I thought I would not mind coming here if I had to have some elective surgery. Just felt so open and so spacious, inviting, and not at all like clinical, if you get sort of like my meaning from that. So can you tell me how was Chase Farm designed to, let's say, address specific problems of the present and the future? And I know there was some obvious constraints that you had to work with from a space and a clinical process design perspective. So what were the most important aspects of that journey, and what learning has it generated for you?
Okay, wow, thanks, Dee. And Rob, I'm going to try not to go down the consultant offices rabbit hole. Happy to take questions later on that one. But yeah, so just to put in context, Chase Farm sat on nearly 15 hectares of land, the old site, and it was a sprawling site, lots of bungalows and porter cabins, all fashioned together. And we had, if you can believe it, a milk float that we used to take patients from outdoor surgery centres to wards. It was, when I came here, I was, what's that? Oh, we transfer patients in. That's brilliant. That's the sort of site we had. We were still burning oil for our energy, and we were shedding millions in estates costs every single year. So there were many drivers from an estates point of view about why we needed to create a new build. But the big piece that sat behind our SOC, our strategic outline case, was the clinical strategy for not just the Royal Free London group, which we had stood up at that time, but it was for what the driver was around population health at the time in North Central London. So we're crying out for more elective, ring-fenced elective capacity. So we had a really clear steer. We had a really clear clinical strategy to work from. And we were in a lucky position where with some support from the Treasury, we had an awful lot of land to sell. So as I say, we sat on 15 hectares. We now sit on 5, so the rest was sold, and that's why we've got predominantly the shiny new building that we've got here today. But we had to build something that was flexible for the future, because the growth has been enormous around planned care, and all the population health data is pointing at we're just going to need more and more of this. So we had to really have that in mind when we were looking at the constraints of what needed to be in this building. We needed to do more than we were delivering on the site the old site, and it needed to be flexible, that in the future, should we want to grow, we can do that. So the design of the building, and it's pretty timely actually, because we're literally just in the SOC stages now of an expansion plan at Chase Farm. So the original build was designed so that we could, essentially a bit like Lego, I am oversimplifying it, the estates director will kill me, but we could bolt on additional floors to the existing build with minimal disruption to activity within the building. So it was designed with that in mind. Now, to sit on a smaller hectare of land, if you like, we really needed to think about the utilisation of the building. So our sprawling site that we had was really poorly utilised, and one of the reasons for that was it wasn't flexible space. So diabetes had the diabetic centre, we had the rheumatology hub, we had the MaxFax hub, and when all those guys were on holiday, no one went in behind them, so this space sat empty. We had buildings of offices, consultant offices, only time I'll mention it, but then we didn't have any flexible dynamic space. So the new building has been completely fashioned on generic repeater space. And as such, from literally the day we opened the doors, we have, across our outpatients, for example, we can honestly say we are over 96% utilised in our rooms every morning and afternoon session, Monday to Friday, because if MaxFax aren't here, someone else is going in behind them. We don't have those obstructions around, they don't have the right kit in the room, it doesn't have a window, that's not the chair I like. All of that went overnight with the new building. The design of the building is entirely flexible. And another example of where that's come into play, Rob mentioned obviously the great big C word, COVID. None of us could see that coming, but when it did, Chase Farm was able to very quickly, flexibly utilise its space to support North Central London in delivering cancer outpatients on low risk pathways, something that the sites with EDs and bulging ICUs just couldn't manage. So we were able to keep going in a way that we wouldn't have been able to do in our old building, and something that wouldn't have been able to support that element of sort of target plan care on the hot sites in North Central London. So it was really incredibly important for us to have this flexible space. It had to sit on a smaller site and be able to deliver more. So what were some of our obstructions? You asked me about obstructions to that. So staff, really key for us, engagement of staff. And in fact, when we went into the build day, we dedicated OD support to that, and to make sure that we could manage the psychology of change with staff as we move through the process, that they were part of the design, the commissioning, the move, and in some way actually owned a big chunk of that. So that was incredibly important, the staff engagement. We were clinically led. So much like the points that Rob was talking about earlier, and actually Chris earlier as well, if you have a clinical leadership team, it does cut out quite a bit of noise and myth busting that you can spend a long time in the circuit of trying to unpack. So when we were challenging activity, for example, and clinicians were describing, well, I need to have 3 rooms to deliver this clinic because my nurse sits in this one, I sit in this one, and then patients prepped in that one. We understood that, we would be able to challenge that in the right way, spend a lot of time observing those pathways, and be able to come to the table with new ways of working that were appropriate and not a threat. And to that end, we were able to, I see Jim's question in the chat earlier, we were able to practice a lot of that transformation in the old building before we moved across. So for example, we wanted to deliver a patient-led navigation system within our outpatients. So we rehearsed that in the old building. We built a lab of all that new tech that we wanted to be able to trial, the systems that we were going to commission to help us deliver that, receptionless model, and practice it small, but we practiced that in live clinics with the clinicians. They felt like they owned the process. They were able to tweak it, break it, mend it before we brought it into the new building. And we did as much of that in many of the other models of care that we built on the old site prior to moving across, and that really helped us with the staff engagement and designing something right first time. So that, you know, if I could press on you to do anything, it would be that engagement piece with clinicians, and keeping it simple. No mass consultations. We did not take that approach here in the design phase or the commissioning phase, and we kept the governance really flat. So we were able to locally hold decisions around the build and the programme as it developed, rather than having to take it through, you know, every division, every directorate, and all the way up to you know, group board. We were able, that was empowered. We were empowered as a programme team to be able to just get on and do, and that was incredibly important for the pace and the delivering the project on time, which we did on time and on budget, and that went a long way to doing that. Is that flat hierarchy and that governance structure, and being clinically led. 100% that supported that. And I think when it's clinically led, a little bit to the point Newcastle were making earlier, when you cut out all of that noise, you're able to then demonstrate to the workforce that this isn't an IT project, it's not a construction project, it's a clinically led program, and linked to a clinical strategy. So the buy-in is there right from the start. And so then when you're seeking solutions, it becomes a solution to solve an operational or clinical problem or challenge, rather than, oh, here's a great bit of kit or tech, let's bung that in as well. You know, it really did have to fit together and solve the operational challenges that we had. Does that answer the question? It was a bit of two-pronged question, Dee.
It was, and I will have more for you afterwards, but thank you very much for that, Amanda. Just before I move on to Newcastle, you have reduced your footprint by 2/3. What about your throughput? So have you been able to reduce your footprint and increase your throughput?
Yes, so absolutely. So again, I mean, COVID really did light the touch paper for that, because a bit like Rob's strategy around delivering 50% outpatients virtually, our aim in the original SOC was to deliver 30% in line with the sort of national target that was hovering around at that time. And as a result of that, activity across the site for outpatients alone, we're delivering 180% of pre-COVID activity through this building now, and whether that be through face-to-face clinics or through telepods, which were built into the building. Again, when we built them, we thought, do you think we'll use them? Now we wish we built 3 times as many, and again, they take up so much less of a footprint, but we're delivering all of our virtual clinics through that space. So yes, activity up. Same for within theatres as well, because it's a purpose-built centre. We have a real sort of racetrack process up on our theatre floor, so it's designed to pull patients through. So again, we're seeing far more operations being performed on the site in the same number of theatres. And we put more innovation into the building than we had in the old site. So we have a barn theatre here. So our productivity through the barn is greater than we would have seen through standard theatres in the old site, as another example. Our ward is co-located with therapies. So again, we're doing same-day mobilisation. We're seeing same-day discharges for hips and knees now, something we'd never have achieved on the old site. So there's a number of things that just stop overnight when you come into a new building, and then there's a number of opportunities that the new building has afforded us to be able to try new innovations, try new models of care that have seen the sort of levels of efficiency we've got now today.
That's amazing. Amanda, thank you very much for that input. I will be coming back to you afterwards with there's another couple of nuggets that I believe that you would be able to share with us. I'm moving on up to Newcastle. And so we come now to sort of like the more of the micro level on the inpatient area. So I know you have done redesign and in your sort of like your inpatients and your outpatients. Is it a new ICU that was built there? And can you talk a little bit? I don't know who's going to, whether it's Chris or Allison will take this one, but pointed to Chris. Chris, can you tell us a little bit about your ICU journey and experience?
So we're currently in the process of redesigning a wing to be built. And in that wing will be a ICU, a specialist burns unit. They're moving over some of the respiratory wards as well, and the dedicated CF unit, and also having some outpatient areas as well. And I think for us, it's about using our knowledge and experience of that patient journey to try and enhance that within the clinical areas. And one of the things that we really are keen and looking for is looking at the bedside devices that patients use, so the TVs that we would normally see, and how we can integrate virtual visiting within those devices, but also utilising them for medical reasons as well. So thinking about video clinics with other consultants that maybe aren't on that site, because we currently have 2 sites. We have one on the RBI and we have one at the Freeman. And sometimes those specialists might not be on site, so it's how can we use those devices to help enhance the patient's journey, reduce delays to be seen by specific specialities, but also to get that clinical input for those patients at the right time. Obviously, we are a tertiary referral centre as well, so COVID has probably matured a lot of the public far greater and far quicker than what we expected. And it's how can we utilise that equipment as well to make sure the patients are engaged with the families, thinking about, do families want to dial in and have a video conference with the patient there and the consultant to get that feedback, but also trying to maximise as much as we can for their comfort, whether that be through hot meal ordering, utilising it for the lights and things in the rooms that they have. So really trying to understand what they want and what the staff feel. One of the other things that we'd identified as well is learning from experience from an infection control point of view, is we know that nurses are really busy, and when they go into a cubicle, they tend to take what they think they need. When you get in there, you tend to need more than what you thought you need. And how can we utilise telecoms and intercom systems to be able to request assistance in the rooms without having to take all your PPE off, going out into the PPE. So those are the type of things that we're really looking at. And one of the other things from a rooms point of view and utilisation of rooms is looking at artificial intelligence, utilising cameras and telecom systems that we put into the rooms to scan the room to see whether actually anybody's in there, and utilising that room, because we all know people put block bookings in for rooms, maybe go once or twice, never ever go again, and then that room's never used for somebody else, and you might need a room last minute. So how can we utilise that technology as well to try and make sure we're utilising the space the best possible way?
Excellent. Thank you very much, Chris. And Allison, can I ask you, what have you been doing around the outpatient redesign and workflows?
And so the main thing for me was we had some engagement sessions with the key clinicians who would be using those outpatient areas. And it was very much about blue sky thinking. If you could have anything that would make your life easier and your patient's journey easier, what would it be? It was a struggle at times, because sometimes people can't see outside of the box. So it was having the ability to give suggestions that maybe have thought about, would you consider this, would you consider working this way, or have you thought about using the rooms in that way? Because as Amanda said, people are very much stuck at saying, well, we need 3 rooms, we need 2 rooms. Maybe you don't. What if we could enhance your service by delivering it in a different way, and giving them not the solutions but suggestions on how we could work differently. And as Chris alluded to, COVID's really pushed us along that journey, and patients and their relatives are could be very tech savvy, and they know, why can't I Zoom? Why can't I FaceTime? Why can't
exactly.
if the technology is there, why can't we use it? Looking at the data that suggests that treating somebody on day 3 rather than day 5 would improve their journey, and they would be discharged more quickly from a service. That was really important. But also looking at the patient's journey, and one of the suggestions, which was a bit of a scare moment for me, was what was described as tracking the patient, giving them a tracker so you knew where they were in the building. And it was a bit like, oh, is that spying? But actually, it's about how they are moving through the building and moving through the service, and how can we enable that journey to be much more smooth or better for the patient. Looking at DNA rates within certain clinics, as Chris said, we are a huge tertiary centre. We have patients travelling from all over the region, and yes, we deliver services elsewhere, outreach services, but sometimes we need them in the actual building to see them. If you give somebody who's living 70 miles away a 9 AM outpatient appointment, the likelihood is they're not going to get there, especially if they're using public transport. So having a device where the patients will receive their appointment, but maybe be able to change that, go on the app, change your appointment, what time's your bus scheduled, and using again artificial intelligence to pull that data. This patient's always 15 minutes late to an appointment that's a quarter past the hour. Right, well, let's give them a half past the hour appointment if that's the time they can get there. Using the information we've already got to redesign the service, as well as making sure that the service is in a position to, when new technologies come online, we're in a position to pick them up straight away. There's not more building work or more network points or more infrastructure work that needs done. One of the big things is the RVI site is a bit of a mishmash of buildings. We've got a Victorian building, we've got a 60s building, and we've got about 2005 building, which is very much an airport lounge look. We've got areas in all three of those locations that have got no Wi-Fi connectivity. So as a patient sitting in A&E, in the ED, can't communicate with their relative to maybe sit at the car park, because we're only letting one person in, because they've got no Wi-Fi connection. There's no connection. They can't get on 4G. So it's looking at things. How can we enhance that? How can we have a patient in outpatients who can't bring a relative with them? How can we bring that relative into the room using technologies? Having that three-way conversation. So that's really where we're up to with the outpatients. It's not the main outpatient department that's moving. It's more about the specialist clinics and how we can deliver those services more smoothly for the patient.
Well, I have to say, Allison, if Maslow's hierarchy of needs was to be redesigned, I think the very bottom rung would be Wi-Fi connectivity for patients and relatives, and then build on that. Thank you very much for that input from Newcastle. I'm just doing a time check. We have about 13 minutes left. We can open to audience questions, or you can talk to each other. But before we do that, there's one term which I absolutely loved. I love a good new term that's actually personal and means something. And when I was talking to Amanda, and I was asking about how you find how people can become involved in designing the hospital and healthcare spaces of the future. You really impressed me when you said it is the people. You have to have the desire to become involved, and we can always build the skills afterwards. And you used the term born improvers. Would you elaborate a little bit on that, please, Amanda?
Yeah, happy to, Dee. So when we were speaking yesterday, I was describing to you something we put in place, still evolving now after the Nightingale, after the first wave of COVID, which was we adopted their learning system that they put in place there. So there you can imagine they were designing things and implementing things by the hour to get that thing up and running. And we went and looked at that model just before it closed and was decommissioned, and have put it in here. Now, the learning system for us, what that actually looks like is we have some funded posts. We have bedside learning coordinators. They are not aligned to a service in the building, and they are out there looking for opportunities to learn every single day. And that can be such a variety of things. But where we've evolved it to now is they're out there looking for those born improvers, the right attitudes in people that will be able to get on board and help us in when we're redesigning, when we're improving, when we're doing transformation, when we're doing innovation. We want folk out on the shop floor at the coalface that are able to own that and take it forward. So we have a framework now within that learning system of being able to identify those born improvers, those guys with that absolute desire, that thirst to change things, improve things. We will take them in and we will skill them in QI, in processes of change. We will link them in with our innovation and digital teams so they can see what the art of the possible is. And those skills I was talking about yesterday are those QI skills, are the transformation skills, project skills. But what we're looking for is the attitude first. Have they got that absolute commitment and energy to do the delivering? Because for us, top-down change doesn't work. The bottom-up change works in the sense that it's sustainable and it will keep itself going. We can step away tomorrow, and there's enough champions here in this building that will keep that culture flowing through, you know, the next raft of change that comes. So that's what we've got. It is very much evolving, Dee. It's been up and running for about a year now, just over a year, that learning system.
Right, and so I've got a bit of feedback coming there. I think if you find your born improvers, then they know, and if you say as they're coming into a structure which has got a flattened governance, then they're going to understand that their involvement really matters. And so do you think that has made a difference as well, your more flattened governance structure?
100%. And look, I've worked in all sorts of different hierarchies, but we're quite lucky here. Well, I say lucky because I prefer the flat hierarchy, but you know, if you're a ward manager here at Chase Farm, you've got you look up and you've got your matron, me and the chief exec. That's how flat it is. And our doors are all open. It really is. It is like that. There's no office in this building that has the chief exec's name on the door. They hot desk like I do, like everybody else does in the building. So it's not just flat in the sense of an organogram structure. It's flat in how it looks, how we all interact with each other, and that for me is what's creating that culture of, you know, people will stop us in the corridor and go, "Have you thought about this? What about this? Can we do that?" And that's, you know, that's really hard to, I don't know how you can teach that or put that on a PowerPoint and share that. That's something that has been grown organically here, and we're incredibly proud of it and very lucky to have it. And I recognise that it's not, you know, it's quite rare still.
Excellent. Has anybody got anything to add to that? Roy, I see you have joined us on screen and on camera there. Is there anything that you would like to say or ask the panelists?
Sorry. Look, I mean, this is all very familiar territory for me. I've been talking about change and the management of change, and for the last 50 years. People love change when they feel they're in charge. That's all you need to know about the management of change. People love change when they feel they're in charge. And that's, of course, what's happening with Amanda. You just put people in charge. There's something I would say, I think, that comes out of COVID. I mean, COVID has been a disaster for families, for colleagues, for the nation. It's been an absolute tragedy. But also, it's been a fulcrum point of change in so many ways. And, you know, we've been running a campaign called No Going Back, where people have instigated change and from the operational standpoint during COVID, and they want to carry that through. And I think that you know, one of the great things about change is that you respect the past and take the best of it into the future. And that's what we must do with COVID, I think, because each of us, I think, are now COVID custodians. We are custodians of the good things that have happened during COVID, and we owe it to the people who've had tragedies to take the good things such as they were and implant them in what we do going forward. So it's about, you know, how we deal with outpatients. It's about how we deal with connectivity. It's about how we deal with connectivity. And so I'd like us all to think about being a COVID custodian and what each of us can do to protect, preserve, and roll into the future the things that we did differently that were for the better during COVID. And I think if we don't do that, we'll lose a treasure house of huge improvements.
Very true. Very true.
And,
Okay.
and also I've got a test for your new hospital. Can a nurse who weighs somebody have the results of the weighing taken automatically through the ether from the weigh scale into the patient record without having to press a button, write anything down, make a note, or type it in? That's my key. That's the one thing that I find hospitals can't do. That's my acid test. It's the weighing a patient test.
They can do it.
Yes. we have full device integration, Roy. No
Very
pens
good.
and pens here.
As soon as I can, I'm going to come and visit you, and you can weigh me. And we'll put it. It's my acid test.
Perfect, perfect. Well, it sounds like Chase Farm has passed that with flying colours. Just in the last couple of minutes left. Okay, 4 panelists, 4 minutes. I'll start with you, Rob. I'm just, because we started off with saying, how do people become involved in the design of the health and care premises of the future? What would your advice be to anybody that wanted to, let's say, follow in your footsteps or get involved in the future design of the healthcare systems?
Good question. I suppose it's making your managers aware of that. I mean, I think certainly that when there's been the opportunity to volunteer, I've always volunteered to be involved. I think if there's the opportunity for you to attend service user groups, so we've done lots of service user groups. Some departments we've had great attendance, some departments we've had really poor attendance. And I think there's always, there's the ability to be able to get your voice heard. If not, then you need to, we have abilities within our organisation where you can contact someone anonymously and say that you'd like to, that this is a potential opportunity that you see and you'd like to be involved. And we're really good at getting feedback from that system. So maybe the organisations that you work in may have something like that. And I think if you ask questions, I think people always pay attention to people that ask questions and want to know. So I think it's always really good to ask the right questions to the right people, because the more you do, I think people, as Amanda's kind of highlighted, you can see that you're interested in those areas, and that often alerts people just to the fact that you're eager to learn.
Excellent. Thank you, Rob. Allison, moving up to you, what would your advice be to anybody wanting to follow in your footprints, let's say in relation to digital transformation, informatics, service design?
I think what's really important is to give staff that broad experience. So from students onward, students upwards, we are in the process of getting our first cohort of student nurses to be with the digital health team. And AHPs. I think it's the unknown of what's out there for them. Also getting staff nurses being able to rotate into our service to see what it is we do and working both clinically and in with the team. So 2 days a week with us, 2 days a week on the ward, and building that, future proofing the team, showing staff what is out there. So don't make specialist services so special that people don't know what's out there.
Very good point. Yeah.
There's a lot of pockets of good work out, good teams out there who people know very little about. So why can't a nurse go in to work with the states?
Yeah.
Why can't they go in and have a look what's going on? And that's really important, because you don't know where you want to be until you've been there.
Very good. We are almost up on time. Chris, anything that you would add to that?
Not really. I think as nurses, it's about having that voice to make sure that you have that impact to learn from your experience and an opportunity to change the future. And actually those coal-based users are the key people to engage to make sure that these services are fit for purpose 5, 10, 15, 20 years down the line. So for me, it's really engaging with those frontline staff.
Completely agree. Amanda, do you want to take us out? If Shane will give us 30 seconds, what would your advice be?
My advice would be curious, be inquiring, and stick your head over the fence and go and look at what everyone else is having a go at, because we have got so much talent in the NHS, so much, but are notoriously bad at sharing it, or sticking your head above the parapet. So get inquiring, get curious, go look, go and network, go and look at some of the tech organisations that are around us. They've been busy as well in the last 20 months developing things. So I think that if I could say anything, it's just, that's how you start, is just go and equip yourself with a bit of what's going on elsewhere.
Well, look, I cannot say thank you enough to Rob from your Whips Cross project, Amanda from Chase Farm, and Allison and Chris up there in Newcastle. Thank you. I think that has been a fabulous session, which is in accordance with the Academy of Fab thing. I think we've hit the nail on the head, and I hope many people will listen to the recording over the next year and become more involved in the design of the future. So from myself, Deirdre Stewart, and the Academy of Fab stuff, thank you.
Thank you very much, Deirdre. Thanks to you all, I guess. Thanks to our audience. And thanks to Cerner UK for your continued and long-standing support. We can't put on these events without you. Enjoy the rest of your day. Thanks for sharing. And do share on Twitter and continue to promote all that we do. Thanks, and thanks for all that you do too.
Thank you. Bye-bye.
Bye.
Bye.